So this morning we are honored to be joined by Dr. Cunningham. So she is joining us from the NIDCD, where she has been since 2011. So she is has a PhD and was an audiologist prior to partaking in basic science research, but she's initially got her training from the University of Tennessee and then did her clinical fellowship in audiology at Indiana University, my home state, and then got her PhD from the University of Virginia. She's done postdoctoral fellowships at the University of Washington in Seattle and was working at MUSC in South Carolina, where she did some of her initial work in heat shock protein mediated protection against ototoxic drug-induced hearing loss. So we'll hear a little bit about ototoxicity and hearing loss this morning, and we're very excited to have you join us.
Thank you so much, Dr. Ellspermann, and thank you for the invitation and the kind introduction. I'm excited to talk about cisplatin-induced hearing loss today, and I want us to discuss whatever you want to discuss. So as I move through, if you have questions or comments or want to have a discussion instead of a lecture, just speak up or raise your hand and let me know. So in terms of disclosures, the only one is that I do intend to describe a potential off-label use of a class of FDA-approved drugs. So the topic of the morning is cisplatin-induced hearing loss. Cisplatin is among the most widely used and effective anti-cancer drugs in the world. It saves millions of lives. It's used to treat a wide variety of solid tumors in both pediatric and adult cancer patients. Cisplatin is the most ototoxic drug in clinical use, and it causes a significant permanent hearing loss in about 50% of the patients who receive the drug. So this is a significant clinical problem, and there is an unmet clinical need to develop therapies that can protect the hearing of cancer patients undergoing cisplatin therapy while not interfering with the therapeutic efficacy of cisplatin. So let's take a look at cisplatin-induced hearing loss in adults. I'm showing you here some of the types of cancer that cisplatin is used for. They include head and neck, testicular, lung, and other solid tumor types in adults. You can see that the incidences of cisplatin-induced hearing loss vary widely, but they can be quite high as 70% of testicular cancer survivors, and in some studies as high as 100% of head and neck cancer survivors, although in our hands, this number is closer to 70%. Factors that influence susceptibility to cisplatin-induced hearing loss in adults include the cumulative cisplatin dose. These different cancers are treated with widely different cumulative cisplatin doses. The presence or absence of concurrent cranial irradiation. This has been reported in many studies as also contributing to the susceptibility to cisplatin-induced hearing loss. However, with more recent radiation protocols, we see in our most recent study that the radiation did not contribute to the cisplatin-induced hearing loss. So I think that the more modern radiation protocols are resulting in less hearing loss caused by cranial irradiation. And another factor that influences susceptibility excuse me, to cisplatin-induced hearing loss is whether there was a previously existing hearing loss. When we take a look at cisplatin-induced hearing loss in children, approximately a third of children with cancer receive cisplatin therapy, and about half of them have a significant permanent hearing loss. Cisplatin is used to treat several solid tumor types in children, and some of these cancers are cancers of very early childhood and occur in children before the development of speech and language skills. So the hearing loss that develops can severely impair the development of speech and language skills, as well as social development and academic development. And you can see again that the incidences of cisplatin-induced hearing loss in children can be very high. Factors that influence susceptibility to cisplatin-induced hearing loss in children include age. Younger children are more susceptible than older children. Again, the cumulative cisplatin dose. Again, the presence or absence of concurrent cranial irradiation, and whether or not during the child's treatment, they require any other ototoxic drugs. So when we look at what damage cisplatin causes to the inner ear, it's quite different from the other major class of drugs that causes ototoxicity, which is the aminoglycoside antibiotics, which cause which cause hearing loss primarily due to death of hair cells. While cisplatin does kill hair cells in the inner ear, it also kills a variety of other cell types, including supporting cells, cells of the stria vascularis, and the spiral ganglion neurons. So once cisplatin enters the inner ear, it wreaks havoc on several cell types. So our lab at NIDCD is called the Laboratory on Hearing Biology and Therapeutics, and we conduct basic translational and clinical studies aimed at understanding and preventing hearing loss, primarily hearing loss caused by ototoxic drugs. So our basic science studies are aimed at understanding the cellular and molecular mechanisms that underlie sensory hair cell death and hearing loss in response to ototoxic drugs. Our translational studies are designed to then use that basic mechanistic knowledge to guide the rational development of therapies aimed at preventing drug-induced hearing loss in humans. And then our clinical studies test the efficacy of these potential protective therapies in humans receiving ototoxic drugs, in this case, cisplatin. In order to conduct these studies, the lab uses two major model systems. Our in vitro preparation utilizes whole organ cultures of utricles from adult mice. We use the utricle instead of the cochlea because we're interested in mature mammalian hair cells and supporting cells. And it isn't possible to culture the mature mammalian organ of Corti without the hair cells dying very quickly. However, the mature mouse utricle will survive in culture, and the hair cells show a very similar susceptibility to both aminoglycosides and cisplatin that we see in the cochlea. And our in vivo preparations include mice that are receiving systemic injections of either the ototoxic aminoglycoside antibiotic kanamycin or the ototoxic anti-cancer drug cisplatin. And we test the hearing of these mice using ABRs and DPOAEs. So to begin, one of the basic science questions that we wanted to ask is, why is the cochlea uniquely sensitive to cisplatin-induced damage? Cisplatin is delivered systemically, and many cell types that are not tumors don't suffer the kind of damage that the inner ear suffers from cisplatin. And so why is the cochlea uniquely sensitive to this damage? To begin to address this question, we first had to develop a mouse model of cisplatin ototoxicity. Prior to the development of this model, most animal studies of cisplatin ototoxicity utilized a single injection of a high dose of cisplatin therapy. And there are at least two major problems with that model system. One is when you give a mouse or a rat a single high dose of cisplatin, what you often get instead of an animal with a hearing loss is a dead animal. So that didn't really work for us. And the other major problem with the single injection protocols is that that's not really how cisplatin is administered clinically. Clinically, cisplatin is administered in rounds or cycles of chemotherapy that have a recovery phase in between to allow healthy tissues, including the kidney, to recover. And so we developed a mouse model of cisplatin ototoxicity that was designed to be at least reminiscent of the way that cisplatin is administered clinically. So the way that we do this is we test the hearing of the mice, and then they receive cisplatin, a single dose of cisplatin each day for 4 days. And then there's a 10-day recovery period. And this 4 days of cisplatin administration followed by a 10-day recovery period constitutes a single cycle of cisplatin administration, and we do 3 cycles of cisplatin administration, and then we test the hearing again. And we report the difference between the baseline hearing test and the follow-up hearing test as ABR threshold shift, and you can see that on the graph below. So the first thing you'll notice is that mice that don't receive cisplatin don't have any hearing loss. That's not a surprise. And then as we increase the dose of cisplatin, we see increasing hearing loss. And we also see that the hearing loss in this model is worse at the high frequencies than it is at the low frequencies. So this mouse model of cisplatin ototoxicity provides us with a hearing loss that is similar to what we see in humans in the clinic. So regarding the question of why is the inner ear particularly susceptible to damage by cisplatin, Andrew Breglio, who was an MD PhD student in the lab, asked the question, what is the role of cisplatin pharmacokinetics in the susceptibility of the inner ear to cisplatin? And in order to address this question, he collaborated with Dr. Lauren Amable at the National Institute on Minority Health and Health Disparities. And Dr. Amable's expertise is metallomics. She studies the effect of metals in the body. And we were able to use this technique because the cisplatin has, of course, at the core of the molecule is a platinum atom. And so Dr. Amable uses inductively coupled plasma mass spectrometry, which is a method that is exquisitely sensitive to test metals. And it gave us a method of testing the amount of platinum as a proxy for the amount of cisplatin in the tissues with a very low background signal, because healthy tissues don't contain any platinum. So this slide is just to show you that our tissues from saline-injected mice that did not receive any cisplatin don't have any platinum in them. So what I'm showing you in these gray bars are those 4 days of cisplatin injection, and then the white spaces between are the 10 days of recovery. And you can see that in mice that didn't receive any cisplatin, we don't see platinum in any of the tissues. In mice that did receive cisplatin, in most tissues, what we saw is that during the cisplatin administration period, we see a rapid increase in the amount of platinum in the tissue. And then as soon as the cisplatin administration period ends, we see a rapid decrease in the amount of platinum in the tissue. And we saw this in liver and kidney. We saw it in lung. We didn't see as much platinum entering heart, but we did see this increase and then a decrease in the amount of platinum. We weren't surprised that we didn't see platinum in the brain, because we know that cisplatin does not readily cross the blood-brain barrier. So this pattern was very different when we looked in the cochlea. So instead of this pattern of an increase in platinum followed by a rapid decline, when we looked in the cochlea, we saw that during the cisplatin administration period, we did see an increase in the amount of platinum in the cochlea. However, when we stopped administering cisplatin, the amount of platinum in the cochlea did not decrease. It remained steady. And so what we saw, instead of an increase and then a decrease in platinum, was just a progressive increase with successive cycles of cisplatin administration, suggesting that cisplatin enters the cochlea, but it doesn't exit the cochlea very well. And in fact, Andrew looked 6 months after the last cisplatin administration period, and all of these other organs had returned to baseline in terms of their platinum, but the cochlea had not declined, suggesting that the cisplatin is retained in the cochlea indefinitely. So we wanted to ask if this is also true in humans, and in order to address this question, we collaborated with the Temporal Bone Bank at the Mass Eye and Ear. And the Temporal Bone Bank was able to provide us with sections of cochleas from individuals who were treated with cisplatin prior to their death and the collection of their temporal bones. And so we were able to use this ICP-MS mass spec technique to measure the amount of platinum in these sections. And the Temporal Bone Bank was able to provide us with 3 sections from each of 7 different individuals who were treated with cisplatin prior to the collection of their temporal bones. And what I'm showing you on the y-axis here is the amount of platinum that we measured in the sections. And on the x-axis is the amount of time that elapsed between the last cisplatin administration and the time of the person's death and their donation of their temporal bone. And the green circles are age and sex matched controls. And what you can see is that even 18 months after the cessation of cisplatin administration, we can still measure platinum in the cochlea. And we see this in all 6 of our adult patients, and the Temporal Bone Bank was able to provide us with one patient who, a pediatric patient who received cisplatin 20 days prior to their death. And what we see in this cochlea is even more platinum than we saw in any of these adult patients, despite the fact that this pediatric patient received less platinum than any of the adults. And that's consistent with what we know about the fact that children are more susceptible to cisplatin-induced hearing loss. And even though there's only one patient here, it's consistent with the idea that more platinum enters the inner ear of the pediatric patient. So in terms of the basic science question, what are the mechanisms that underlie this sensitivity to cisplatin-induced hearing loss? Our data are consistent with a model in which cisplatin enters the inner ear very readily, and it is not cleared from the inner ear, which can contribute to ongoing cellular damage and progressive hearing loss in the inner ear. So the second basic science question that I want to discuss with you is, what are the intrinsic protective mechanisms? So what are the cellular and molecular mechanisms that cells can activate in the presence of a stressor like cisplatin that might be able to preserve the cellular function and therefore preserve the hearing? So for a number of years, our lab has been studying a class of protective molecules called heat shock proteins. Heat shock proteins are a family of evolutionarily conserved stress response proteins that promote cell survival in a wide variety of living systems. These proteins were first named because they're rapidly induced in response to heat, which we know is a stressor that will kill any cell type. However, it's not a terrific name, because we now know that these heat shock proteins are induced in response to a wide variety of cellular stresses, not just heat. And in fact, induction of heat shock proteins in response to cellular stress is the most ubiquitous and evolutionarily conserved stress response in the entire living world. Yeast do this, plants do it, mammalian cell types do it. And when these heat shock proteins are induced, they have a variety of anti-apoptotic activities that protect against cellular stress and preserve cellular function. So our lab wanted to ask the very simple question, does induction of heat shock proteins protect against cisplatin-induced hair cell death and hearing loss? So to begin to address this question, we utilized our in vitro model system of whole organ cultures of utricles in mice. And to induce heat shock proteins, we did the classic manipulation of a heat shock, which means that we warmed the tissue a few degrees for a few minutes. Not enough to cook the tissue, not enough to kill the cells, but enough to activate these proteins. And so you can see in this Western blot of control utricles which heat shock proteins were already present and control utricles. And in response to heat shock, you can see that some of these heat shock proteins like HSP70 and HSP32 were rapidly induced, whereas others like HSP90 and HSP60 didn't change much. And when we asked if this heat shock protein induction is protective against cisplatin-induced hearing loss, cisplatin-induced hair cell death in vitro, we saw that it was. So on this graph, the x-axis is increasing concentration of cisplatin, and increasing hair cell survival is on the y-axis. And so in the absence of heat shock, you can see that as cisplatin concentration increases, hair cell survival decreases. However, if we heat shock these utricles prior to the addition of cisplatin, we see a significant shift of this dose response curve in favor of hair cell survival, suggesting that heat shock protein induction does inhibit cisplatin-induced hair cell death. Other students in the lab went on to show that these two heat shock proteins, HSP70 and HSP32, are independently protective. So in terms of the basic science question about what are the intrinsic protective mechanisms, our data indicate that induction of heat shock proteins is protective against cisplatin-induced hair cell death. So in order to begin to translate this basic science information into a therapy to reduce cisplatin-induced hearing loss, we next asked, are there FDA-approved drugs that induce heat shock proteins? We were interested in looking at FDA-approved drugs because we were interested in hopefully having a more rapid translation into the clinic, because FDA-approved drugs already have safety profiles in humans. So it turns out that a class of very familiar drugs are known inducers of heat shock proteins, and this is the class of cholesterol-lowering drugs that are collectively known as statins. This is Crestor and Lipitor and Zocor, the generics of which are atorvastatin and lovastatin and pravastatin and so forth. This is a widely used class of drugs that are used to reduce cholesterol in individuals at risk for cardiac disease. And there were two reasons right off the bat that we were very interested in in statins. One is that statins they're very widely used drugs and they have excellent safety profiles in humans. And there are large epidemiologic studies that show that cancer patients taking statins do not have worse outcomes of their cancer therapy than individuals who are not taking a statin. And the other reason that we were interested in statins from the beginning is that statins are old drugs, they're off patent, and the generics are very cheap. A 90-day supply of atorvastatin is $32 at Walmart. So we were interested in asking if statins can reduce cisplatin-induced hearing loss in humans. There were a few other reasons to be interested in statins. As I indicated, statins are known inducers of these heat shock proteins that we had shown are protective in vitro. Other labs had shown that members of this statin class of drugs protected against hearing loss caused by other stressors. For example, simvastatin has been shown to reduce aminoglycoside-induced hair cell death in vitro. Pravastatin has been shown to reduce noise-induced hearing loss in mice. And atorvastatin had been shown to reduce age-related hearing loss in mice. So Kay Fernandez, who is an AUD PhD audiologist in the lab, asked if atorvastatin reduces cisplatin-induced hearing loss in mice using the mouse model of cisplatin ototoxicity that I showed you earlier. And I'll show you a little bit of Kate's data here. Again, these are mice receiving atorvastatin in our mouse model of cisplatin ototoxicity. And so on the x-axis here is the frequency, the normal frequency range of mouse hearing. And on the y-axis, again, is threshold shift. So as you go up on this axis, hearing loss gets worse. And so I'm showing data for females and males because what we saw is that male and female mice responded best to different doses of atorvastatin, but both male and female mice show an incomplete but significant protective effect against cisplatin-induced hearing loss in mice that are also administered atorvastatin. So to be honest, this is not a fantastic protective effect. It didn't blow our hair back, but it did show us that atorvastatin can be protective, and it was enough evidence for us to be interested in asking if statins are protective in humans. And so so the answer to the question, are there FDA-approved drugs that activate heat shock proteins? The answer is yes. Statins protect against cisplatin-induced hearing loss in mice. And so in order to begin to ask the question if statins are protective in humans, we first began looking at some of the large clinical databases that are known to be available. And this is really where I was pretty naive about how I thought it would be easy to get these data, because we know that 2 million Americans are on cisplatin therapy at any given time. We know that millions of Americans are taking statin therapy. And so I naively thought that all we have to do is find the audiograms of these individuals who are taking cisplatin and separate those who are taking statins from those that aren't. So the reason that this was naive is that it turns out that most adults who are newly diagnosed with cancer and are scheduled to undergo cisplatin therapy do not get a baseline hearing test. And so it's not possible for us to work with just follow-up hearing tests in adults because, of course, in an adult, if you have a hearing loss after cisplatin therapy, it's impossible to know how much of that hearing loss is from cisplatin therapy and how much of it was pre-existing before the cisplatin therapy. And so we looked at all these major databases that I'm showing you here, and none of them had baseline and follow-up hearing tests for patients taking cisplatin therapy. And so that was a bit of an education for me. However, we did find two organizations that had ongoing ototoxicity monitoring programs for their adults receiving cisplatin therapy. And these were the University of Rochester Medical Center and Walter Reed National Military Medical Center, which is right across the street from us here in Bethesda, Maryland, at NIH. And so we partnered with these two institutions to look at their retrospective data, and we simultaneously began our own prospective observational study in collaboration with Dr. Nicole Schmidt, who is a head and neck surgeon at Emory Winship Cancer Institute. And what we were able to do is to combine these resources to get reliable baseline and follow-up audiograms on 277 adult subjects. 113 of these individuals were statin users, and 164 of them were non-statin users. They were all adults. They were all newly diagnosed with head and neck cancer, and they were all scheduled to undergo cisplatin-based chemoradiation therapy. We excluded individuals who had a profound hearing loss at baseline because we would not have been able to measure a change in their hearing. So I just want to say one thing about choosing head and neck cancer as a cancer to start with. Head and neck cancer was a good place for us to start because it is a disease of 60-year-old men. And 60-year-old men are exactly the population that tend to be taking these statin drugs. So that's why we were able to have, out of these 277 individuals, 113 of them were statin users just coming through the door. We didn't have to give them a statin, they were already taking it. And so for all of these individuals, we had a reliable baseline audiogram that was within 12 weeks prior to the onset of their cisplatin therapy. They then underwent the full course of all of their cisplatin therapy. And then we had a reliable follow-up audiogram within 12 weeks after the completion of their cisplatin therapy. And so here's just a little bit of information about our subject and treatment characteristics. As I indicated, we had 164 people who were not taking a statin, 113 who were taking a statin. They were all about 60 years old. They were overwhelmingly male, and almost all of them, 99% of them, received concurrent cranial irradiation. You can also see that the enormous majority of them had either normal hearing or a mild hearing loss at baseline. So we again compared the baseline hearing test and the follow-up hearing test and report this as threshold shift, which we're interpreting as cisplatin-induced hearing loss. So the first thing that you'll notice is that in our individuals who are not taking any statin drug, we see a classic cisplatin-induced hearing loss that's worse at the high frequencies than it is at the low frequencies. Among our individuals who were taking a statin drug, we saw a significant reduction in the amount of cisplatin-induced hearing loss that those individuals experienced. So this was our first hint that statin users have a reduced cisplatin-induced hearing loss compared to those who are not taking the statin drug. So because this was an observational study, we didn't have any control over what statin any of these individuals were taking. And so when we looked at what statins were in use by subject in our cohort, it turned out that there were 6 different statins in use by subjects in this cohort. And the only statin for which we had enough data to have statistical power to analyze that statin individually was atorvastatin. So when we looked at our no statin users compared to our atorvastatin users, we saw an even greater reduction in the cisplatin-induced hearing loss than we had seen among our users of any statin drug. So these data indicate that atorvastatin users have significantly less cisplatin-induced hearing loss compared to individuals who are not taking a statin drug at the time of their cisplatin therapy. And so Kate went on to apply a mixed effects model, statistical model, to account for some of the other variables that we know influence susceptibility to cisplatin-induced hearing loss. And so even when we accounted for sex, age, the cumulative dose of cisplatin, concurrent cranial irradiation, and pre-existing hearing loss, atorvastatin use came out to still be statistically significantly related to a reduction in cisplatin-induced hearing loss. So we wanted to apply a grading scale to make sure that the hearing losses that we were measuring were actually clinically significant. So it's of course possible to measure a cisplatin-induced hearing loss that doesn't actually impact the person's communication ability or their need for hearing health care. So we wanted to apply a set of criterion to make sure that the hearing losses that we were measuring are clinically significant, and also to have a measure of the severity of the hearing losses that we were seeing. And while there are a number of ototoxicity monitoring criteria, the ones that we chose to use are the ones developed by the National Cancer Institute that are called the Common Terminology Criteria for Adverse Events. This is a set of criteria that measure adverse events in clinical trials, and they measure all adverse events, including from headache to death. And one of the reasons that we chose CTCAE is that this is a very familiar grading scale for oncologists, who are the people who are administering cisplatin therapy. And so fortunately for us, hearing loss doesn't come in grade 5, which is death, and it doesn't come in grade 4, which is life-threatening. However, it does come in grade 3, which is severe or disabling hearing loss, and 2, which is a moderate hearing loss that we would anticipate would need hearing rehabilitation and would influence a person's ability to communicate. So when we applied the CTCAE criteria to the data in our cohort, this is what we saw. So on the x-axis, you see the incidence of hearing loss in each of these grades. And the first thing that you'll notice is among our individuals who are not taking any statin drug, approximately 30% of them were experiencing these more severe grade 2 and grade 3 hearing losses. So that means that 30% of our head and neck cancer patients are experiencing hearing losses that would definitely be expected to impact their ability to communicate, which really drives home to us the need for these people to have a baseline hearing test and to have audiology as part of their healthcare. When we looked at our atorvastatin users, the percentage of individuals who were experiencing these grade 2 and 3 severe and disabling hearing losses dropped from about 30% among our non-statin users to less than 10% among our atorvastatin users. So again, these data indicate that atorvastatin users have reduced incidence and severity of cisplatin-induced hearing loss compared to individuals who are not taking a statin drug. Our study was underpowered to look at overall survival and disease-free survival, but we felt like we were morally obligated to take a look at this. And so we did not see any difference in overall survival or disease-free survival in any of our groups, our non-statin users, our any statin users, or our atorvastatin users, suggesting that atorvastatin didn't influence the outcome of cisplatin therapy in our cohort. And again, there are large epidemiologic studies indicating that statin users do not have worse outcomes of their cancer therapy compared to individuals who are not taking a statin drug. So in terms of the question, are statins protective in humans? Our observational data indicate that individuals who are taking atorvastatin have reduced cisplatin-induced hearing loss compared to individuals who are not taking a statin drug. So, of course, the study that we did doesn't definitively determine whether atorvastatin reduces cisplatin-induced hearing loss. And in order to do that, we have now initiated a randomized controlled interventional study that is designed to definitively determine the extent to which atorvastatin reduces cisplatin-induced hearing loss. And you can see at the bottom of this slide, our partners in this study. This is a multi-site study. Dr. Nikki Schmidt at Emory Winship and I are the PIs on this study. And the study has been funded and the IRB is approved. The study drug is ordered, and we anticipate beginning enrollment of participants in this study around the end of this year. So we're excited about this study, because if atorvastatin reduces cisplatin-induced hearing loss in our study, clinicians will have a cheap, safe drug that they can use to protect the hearing of adults undergoing cisplatin therapy. So this is a little bit about the design of our interventional study. These will all be adults with head and neck cancer who are scheduled to undergo cisplatin-based chemoradiation therapy who are not currently taking a statin drug. These individuals will be randomized to receive either atorvastatin or placebo. And again, we'll have a baseline audiogram prior to the onset of cisplatin chemotherapy. They will undergo all cycles of cisplatin therapy, and then we'll have a follow-up audiogram. The primary outcome in this study will be the incidence of a CTCAE grade 2 or greater hearing loss, and the secondary outcome will be 2-year survival. So this is a grand round, so I would be remiss if I didn't spend a little bit of time talking about sodium thiosulfate therapy. So sodium thiosulfate was shown in the last several years in 2 major studies to reduce cisplatin-induced hearing loss in children. The first of these studies was published in 2017 by the Children's Oncology Group. And in this study, they enrolled children with all cancers, and they administered sodium thiosulfate 6 hours after cisplatin therapy. And they found that the cisplatin reduced the incidence of cisplatin-induced hearing loss in these children by about 50%. The second study, which was published in 2018 by the European equivalent of the Children's Oncology Group, had very similar study parameters and also found that sodium thiosulfate reduced cisplatin-induced hearing loss in children by about 50%. So this is very exciting. The conclusion from these 2 studies is that sodium thiosulfate halves the risk of cisplatin-induced hearing loss in children. And the FDA approved sodium thiosulfate for use in children with localized cancers in September of last year, so just over a year ago. Sodium thiosulfate is not approved for children with metastatic cancer, and it is currently not approved in adults. So those children and adults for whom sodium thiosulfate is not approved don't currently have a therapy that can be used to protect their hearing as they undergo cisplatin therapy. However, there are currently at least 7 ongoing clinical trials using sodium thiosulfate to reduce cisplatin-induced hearing loss in patients with a variety of cancers. So this is very exciting because it means for the first time that pediatric oncologists have a protective therapy that can significantly reduce the risk of cisplatin-induced hearing loss in children undergoing cancer therapy. Because sodium thiosulfate acts by binding cisplatin and inactivating it, that's why they separate the sodium thiosulfate therapy 6 hours from the cisplatin therapy. It's also why sodium thiosulfate hasn't been approved for children with metastatic cancer because of the theoretical risk of sodium thiosulfate reducing the therapeutic efficacy of cisplatin, although that risk hasn't borne out in the studies that have currently been done. So it's unclear if sodium thiosulfate therapy is appropriate for kids with metastatic cancer, and it's also unclear if it's appropriate for adults. When I talk to oncologists about sodium thiosulfate therapy, they suggest to me that it may not be readily adopted among adults for two reasons. One is because it makes the day 6 hours longer for these cancer patients, because you have to have this 6-hour separation between STS therapy and the cisplatin therapy, and also because the STS therapy causes severe retching that is definitely related to the infusion. So it's unclear if this will be adopted in adults, but it's very exciting to have this therapy available for children. So the last thing that I want to tell you is that we are continuing to gather clinical data on individuals who are undergoing cisplatin therapy. Since Kate and I have begun talking about our study on atorvastatin, several other groups have come to us and indicated that they have ongoing ototoxicity monitoring programs, and they have contributed data to a growing database of hearing tests on patients who have undergone cisplatin therapy. And we're really grateful for all of these partners that you see here, because they're allowing us to use this additional data to begin to address other questions, including whether we see progression of the hearing loss and whether that progression is different among atorvastatin users. And it's also beginning to allow us to look at other cancers beyond head and neck cancer, and also to look at other statins beyond atorvastatin. So this is really brought to the forefront of our minds the need in our field for robust, accessible clinical databases. And it's we're really grateful for our partners who have contributed additional data to this effort. So to summarize what I've talked about today, cisplatin is the most ototoxic drug in clinical use. It results in permanent hearing loss in both pediatric and adult cancer survivors. Our data indicate that cisplatin is retained in both the mouse and human inner ear indefinitely, that the cholesterol-lowering drugs known as statins reduce cisplatin-induced hearing loss in mice, and our observational data in humans indicate that atorvastatin use is associated with reduced cisplatin-induced hearing loss in patients with head and neck cancer. And we also talked about sodium thiosulfate, which is now FDA approved to reduce cisplatin-induced hearing loss in children undergoing cisplatin therapy. So it takes several images for me to show you all of the terrific people who have worked on the projects that I've discussed with you. I'm really incredibly lucky to work with this very talented group of scientists and clinicians. And I'm really grateful for all of their effort and energy and expertise, and also for all of our collaborators, both at NIH and at other institutions.